1, 2,
And review, somebody email.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's, charge
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
So, if you are admitted to a psychiatric hospital today, your actual medical diagnosis might, matter significantly less to your long-term survival than your home address.
Yeah, which is, it's a completely startling reality for a lot of people to wrap their heads around.
Right, because the most critical medical procedure you're going to undergo isn't a brain scan.
No.
And it's not a medication adjustment either. It's actually your discharge plan.
Exactly. And we're so conditioned, to think of healthcare as this highly contained, very linear event.
Like, you break a bone, you go to the hospital.
Right. The doctor resets it and you go home cured. The hospital is the central character in that whole story.
But when we step into the world of mental health and, modern psychiatric care, that hospital building is just this tiny microscopic fraction of the story.
Yeah, a blip on the radar.
Because the real work, the messy, complicated, life-saving work, it happens everywhere else.
Out in the community.
Exactly. And that is exactly what we are unpacking today. We're pulling from this comprehensive breakdown of modern systems of mental health care and rehabilitation.
Which is such a massive topic.
It is. But whether you are, a nursing student furiously prepping for your clinical exams or just someone who is intensely curious about how our healthcare system actually operates, this deep dive is custom tailored for you.
We are looking at this huge shift from sprawling, isolated institutions to community-based care.
And we'll examine why that discharge plan is quite literally a life or death matter.
Right, and how interdisciplinary teams are out there fighting every single day to keep vulnerable populations from, falling through the cracks of what is, let's be honest, a deeply flawed system.
Yeah, deeply flawed. So to understand how psychiatric care functions right now, I feel like we have to look at the mechanics of how we got here.
Absolutely. History is crucial here.
Because if you look at a psychiatric hospital stay today, it is shockingly brief.
Oh, yeah. We're talking days.
Sometimes just hours, right?
Literally hours in some cases, yeah.
Yeah. But think about the landscape before the 1950s. The standard of care, really the only available strategy at the time was isolation in these massive state facilities.
And we really shouldn't even call them hospitals in the modern sense.
Or were they then?
They were asylums. People with chronic, persistent mental illness weren't staying for days or weeks. We were talking about stays that lasted months, years.
Or a lifetime.
Yeah, an entire lifetime. It was essentially warehousing.
Wow.
Because the medical field simply didn't have the tools to treat the underlying chemistry of severe mental illness back then.
But then the 1950s hit and the landscape completely fractured, right? In the best way possible.
Totally. We saw the introduction of psychotropic medications.
Which changed everything.
It was a massive beacon of hope. Suddenly, there was an actual way to chemically regulate the symptoms of psychosis, severe depression, mania.
And that medical breakthrough, it basically became the catalyst for a massive social and legal shift in the 1970s.
Right. As patient symptoms became manageable with these new drugs, the legal focus turned heavily toward client rights.
The concept of the least restrictive environment.
Exactly. For anyone studying healthcare policy or prepping for nursing boards, this is a foundational concept.
Because the state could no longer justify locking someone in a facility indefinitely if they could be safely treated in their own community.
Right, which birthed the deinstitutionalization movement. Those massive state hospitals just began to empty out.
And the intention there is beautiful, right? The idea was that the funding would follow the patients out of the hospitals and into robust, localized community treatment programs.
That was the dream, yeah.
But the reality is that the funding never actually followed them.
Not at all.
Budgets were slashed, those community centers were never built to the scale that was required, and we were just left with this massive vacuum.
Which brings us right to today, where managed care absolutely dominates the landscape.
Okay, let's unpack this. Managed care fundamentally altered the mechanics of an inpatient stay, didn't it?
Oh, fundamentally. Back in the 1980s, you still had something called milieu therapy.
Milieu just meaning environment, right?
Exactly. The idea was that the hospital ward itself, like the interactions with other patients, the structured daily routine, the stable patient's modeling behavior for the newly admitted ones, that environment was the medicine.
But that requires time.
So much time. And today, managed care relies on cost control measures.
Like utilization reviews.
Right, which means an insurance company is constantly looking over the doctor's shoulder, requiring the hospital to prove, sometimes every 24 hours, exactly why this patient still needs to be occupying a bed.
Because the acuity is so much higher now. I mean, patients are incredibly sick when they are admitted.
Very sick, yeah.
And they are staying for a fraction of the time. The modern inpatient psychiatric unit feels less like a specialized garage that takes the time to completely rebuild a broken engine.
I like that analogy.
Right. Much more like an emergency pit stop in a Formula One race.
Yes, exactly. It's rapid assessment.
Stabilization of acute symptoms and immediate discharge planning. The tires get changed, the gas tank is topped off, and you are pushed right back onto the track.
Yep.
But I have to ask, does this pit stop model actually work, or are we just pushing sick people out the door to save money?
Well, what's fascinating here is that the data on this is actually completely counterintuitive.
Really?
Yeah. Research indicates that short hospital stays can actually be just as effective as longer ones.
Wait, just as effective?
Yes. Clients who spend fewer days in the hospital are just as likely to attend follow-up programming. And more importantly, they're actually more likely to be employed and show improved social functioning compared to those with longer hospitalizations.
I guess that makes sense. The prolonged isolation of a long stay could kind of erode a person's ties to the real world.
Exactly. But, and this is a massive structural caveat to that data.
I was going to say, there has to be a catch.
A huge one.
Yeah.
The pit stop model only works provided there is immediate, adequate follow-up and community support waiting for them out there.
Which we know is frequently not the case.
Right. When that community system gets bottlenecked like, when there are no outpatient appointments available for 3 months,
Yeah.
we see the grim reality of something called boarding.
Oof, boarding.
This is where clients in absolute psychiatric crisis are held in emergency rooms, sometimes sleeping in hallways for days,
Just hoping to avoid a full admission.
or just waiting for a less intensive service to open up somewhere. It is a symptom of a system where the pit stop is full and the cars are just circling the track running out of gas.
That image of boarding is so haunting. And it illustrates exactly why the hospital itself is just that blip on the radar we talked about.
Because if the hospital is just a rapid stabilization point,
The success of the patient's entire journey hinges entirely on what happens the second they walk out those automatic sliding doors.
which brings us back to that startling reality we mentioned at the very start.
Yeah.
The adequacy of a patient's discharge plan is actually a better predictor of how long they will remain successfully in the community than their clinical psychiatric diagnosis.
Here's where it gets really interesting to me. Let's really look at the mechanics of that. The details of your exit plan, like where you are going to sleep tonight.
How you are physically getting to your pharmacy.
Whether you have food in your fridge, that all matters more to your long-term stability than the actual neurochemical nature of your illness.
It is the ultimate example of how social determinants of health override clinical pathology.
But engineering that perfect discharge plan is incredibly difficult.
Oh, it's monumental. We see major systemic barriers. Things like active substance use, a history of criminal behavior, medication non-adherence, suicidal ideation.
So if a patient is dealing with a dual diagnosis, say schizophrenia and a severe alcohol use disorder,
They are frequently locked out of optimal housing. Most halfway houses or group homes require strict sobriety.
so the patients who actually need the most intense support are actively disqualified from receiving it. They are handed what the industry calls a marginal discharge plan.
Which is basically a piece of paper with a phone number and an address to a deeply inadequate shelter.
And they fall right back into the revolving door. They are readmitted more quickly and more frequently.
Right. To try and stop that revolving door, the system uses bridging mechanisms, like partial hospitalization programs or PHPs.
Well, how does that work?
Well, instead of living at the hospital, a client might go to a day treatment program from, say, 9 a.m. to 3 p.m.
Okay.
They get group therapy, medication monitoring, social skills training during the day, and then they return to their own bed at night. It provides that intensive structure without the total isolation of an inpatient unit.
And for those who don't have a safe bed to return to at night.
That is where residential services come in. Things like board and care homes, adult foster care, group homes.
But this is where medical necessity collides violently with societal stigma, doesn't it?
Oh, absolutely. Finding a quality living situation is a huge task because neighborhoods actively fight against having them there.
Classic NIMBYism. Not in my backyard.
Right. People cling to stereotypes, they fear their property values will drop, or they mistakenly believe that people with severe mental illness are inherently violent.
So how do we successfully transition a patient into a community that might actually be actively hostile to their presence?
Well, if we connect this to the bigger picture, it requires an entirely different approach to the transition itself. There's this brilliant framework called the transitional relationship model.
I was reading about this. They use it in Canada and Scotland, right?
Yes, it utilizes two specific components to ease the shock of discharge. First is peer support.
So pairing the transitioning patient with someone who has a similar diagnosis.
Exactly. Someone who's already living successfully in the community, they serve as like a living, breathing proof of concept.
And the second component is bridging staff, meaning the hospital staff doesn't just wave goodbye at the door and close the file.
Right. The hospital staff physically maintains their therapeutic relationship with the patient out in the community until a solid, trusting relationship is established with the new outpatient provider.
That's amazing. It completely eliminates that terrifying free fall between the hospital bed and the first clinic appointment.
It does.
But for any of these community transitions to actually stick, the entire philosophy of treatment has to evolve. We have to stop trying to simply cure symptoms and start focusing on recovery.
This is a vital concept. You have to understand the fundamental difference between cure and recovery.
Like if you have bacterial pneumonia, you take an antibiotic, the bacteria dies, and you are cured.
Right. The illness is permanently gone.
Yeah.
But recovery, especially in the context of severe mental health, it's not about erasing the illness.
It's about managing a chronic condition.
Exactly. It's about pursuing personal growth, building relationships, finding meaning in the community, all while actively managing symptoms that might never fully disappear.
And one of the most radical, beautiful examples of this recovery model in action is the clubhouse model. Oh, yes. It originated back in 1948 with Fightin' House in New York City. It is what we call an intentional community.
It operates on 4 guaranteed rights for its members, right?
Yeah.
A place to come, meaningful work, meaningful relationships, and a place to return to meaning lifetime membership.
Right. It feels way less like a sterile clinic and much more like a lifelong community center.
The members run the daily operations, from cooking the meals to managing the newsletter. But here is the mechanism that completely shocked me.
What's that?
Taking prescribed psychiatric drugs is not a condition of participation.
It's true. The focus is entirely on health and building a rehabilitation alliance. The clubhouse model recognizes that true recovery cannot be forced.
I have to play devil's advocate here, though, because a lot of people will hear that and panic.
Oh, sure.
Like, is it really safe to let patients with severe, persistent mental illness, like severe schizophrenia or bipolar disorder, participate in a community environment without strictly mandating they take their antipsychotics or mood stabilizers?
It sounds risky to some.
Doesn't that invite chaos and risk? It is the most natural question to ask, but the answer goes to the very heart of why the recovery model works, which is empowerment.
Empowerment.
Yeah. When clients, rather than the clinical staff, make their own decisions about their bodies and their treatment, it builds a profound level of trust. It fosters genuine autonomy.
I see.
The data consistently shows that treating people as adults capable of self-determination ultimately leads to better, more authentic long-term engagement than forcing compliance ever could.
So when they are ready to seek medical treatment, they do it because they want to stay in the community, not because they're being threatened with expulsion.
Exactly. It's a massive paradigm shift.
It really is. And operating on that same wavelength of bringing care directly to the patient, we have ACT, assertive community treatment.
Conceived in 1973 in Madison, Wisconsin.
Right. So if a standard outpatient clinic is like a restaurant where you have to travel there, sit down, and order off their specific menu of services, ACT is like a personal chef who comes into your kitchen, sees you're out of groceries, and actually drives you to the store.
That is the perfect way to visualize it. ACT is essentially a hospital without walls.
Yeah.
It features a very high staff-to-client ratio.
And the services are provided 24 hours a day, 365 days a year.
Directly in the client's home or neighborhood. And there are no arbitrary insurance time constraints on how long a client can receive these services.
That's huge. And they don't just sit in a circle and talk about coping mechanisms, right? They take a direct problem-solving approach to mundane survival issues.
Right. If a patient's anxiety is spiraling because they don't know how to navigate the bus system to get to their job,
The ACT team rides the bus with them.
yes, because if you lose your job and can't buy groceries, your mental health will inevitably spiral. It is holistic care in the truest sense.
But while ACT and clubhouses represent the absolute gold standard of community care, the reality on the ground is brutally unfair.
It really is.
Huh.
Chronic underfunding means that a huge percentage of the population simply does not have access to these programs.
And when that community safety net fails, patients don't just evaporate.
No, they fall through the cracks.
And they land in alternative, deeply inappropriate institutions. The streets, the jails, and a heavily strained VA system.
Right. Let's examine the mechanics of homelessness first. People with mental illness experience much longer periods of homelessness, they spend vastly more time in shelters, and they face overwhelming discrimination.
The federal government attempts to plug this hole with the PATH grant program, right?
Yes, Projects for Assistance in Transition from Homelessness funds direct street outreach and case management.
But the tragic reality is that outreach workers can only do so much.
Exactly. Without broader public policy changes regarding affordable housing, they are just managing the suffering, not solving it.
So what does this all mean? When the streets become highly policed, we see the pipeline shift toward incarceration.
Yes, the rate of mental illness in jails is 5 times higher than in the general population.
5 times. That is staggering.
It is. This is the mechanism known as the criminalization of mental illness.
Meaning arresting people for misdemeanors just to get them off the streets.
Right. It's the systemic practice of arresting and prosecuting people with mental illness for minor things, loitering, trespassing, public urination.
Because the community doesn't know what else to do with someone experiencing visible psychosis on a sidewalk.
So they call the police, and the jail becomes the default psychiatric facility.
It points to a tragic, almost unbearable irony. Society at large often fears people with severe mental illness. The media sensationalizes them as violent, unpredictable criminals.
But the data paints a completely different picture.
Exactly. The reality is that people with severe mental illness are vastly more likely to be the victims of violence, sexual assault, and trauma, both out on the streets and inside those jail cells.
This raises an important question, though. How do we stop this cycle of criminalizing illness?
How do we?
One of the most effective interventions is the deployment of police mobile crisis units.
These are trained mental health professionals who are dispatched directly to a scene once law enforcement has stabilized it.
Right. Instead of putting the individual in handcuffs and taking them to booking, the crisis unit can divert them directly to a hospital or a crisis stabilization center.
We also see the implementation of systemic screening at the jail level, using tools like the brief jail mental health screen right at intake.
Yes. If we are going to arrest people, we at least need to know who we are dealing with within the first few hours.
So we can isolate them from predatory inmates and get them their medications.
Identifying the illness is the absolute first step to diverting them out of the justice system and back into the healthcare system where they belong.
Absolutely. And speaking of populations that require highly specialized diversion and care, we have to talk about our military veterans.
The burden they carry is staggering.
They face compounded overlapping issues: physical trauma, the complex psychological transition back to civilian life, severe combat trauma.
The research also heavily highlights the prevalence of military sexual trauma, or MST, which acts as an accelerant for depression, severe substance use disorders, and eating disorders.
The culmination of these factors results in a suicide rate among veterans that is 1.5 times the rate of the general population.
Right. The VA system provides a massive infrastructure of services, but the inherent military stigma of seeking help,
Combined with the sheer clinical complexity of treating co-occurring disorders.
like severe PTSD combined with an opioid use disorder, it requires a deeply specialized approach.
But trying to untangle that complex web of PTSD, substance use, housing instability, and legal diversion, it is mathematically impossible for one single psychiatrist or social worker.
The math just doesn't work. To actually pull this off, you need an entire coordinated village.
We call that village the interdisciplinary team.
Yes, and it is expansive and highly specialized. You have psychiatrists handling the core diagnosis and complex medical treatments.
Clinical psychologists.
Right. Social workers who focus heavily on the family dynamics and community support structures.
You have occupational and recreation therapists who rebuild functional abilities and leisure skills so a patient actually has a life worth living.
Exactly. You have vocational rehab specialists whose sole job is to help the patient secure and maintain employment.
And pharmacists to manage the incredibly complex drug interactions.
But the absolute glue holding this village together, the ideal case manager, is the psychiatric nurse.
It makes perfect sense when you analyze their specific training. A psychiatric nurse has a holistic foundation in physical health promotion.
Right? They can monitor general medical issues, like a patient's blood pressure spiking or signs of diabetes.
While simultaneously assessing psychiatric symptoms, de-escalating a crisis, and monitoring complex pharmacology.
They speak all the different languages of the interdisciplinary team and translate it for the patient.
And those nurses and care teams are increasingly using technology to reach patients exactly where they are.
Telepsychiatry and e-mental health.
Obviously, it exploded out of necessity during the COVID-19 pandemic, but it remains highly effective today.
It is an absolute lifeline for patients in rural areas who live hours away from a clinic.
Or for patients with such severe agoraphobia or anxiety that they physically cannot face an in-person waiting room.
And the evidence-based validating telehealth is incredibly strong, especially for medication adherence.
Oh, I was absolutely blown away by the study on this.
The follow-up phone call study.
Yes. Researchers looked at kids and teens who were starting new, complex psychiatric medications, and the intervention they tested was shockingly simple.
Just a 10 to 15-minute follow-up phone call regarding their medication adherence on their first day and a few times over the next 3 months.
Right. No new drugs, no intense therapy, just a phone call.
The results illustrate exactly why systems of care matter so much.
A staggering 96.7% of the kids who got those short, targeted phone calls had high medication adherence.
Incredible.
Meanwhile, the control group, who were just handed the prescription and sent home without the calls, had widespread, dangerous non-adherence.
Wow.
96.7% success from a 15-minute phone call. It proves how a cheap, simple, systemic intervention can drastically alter a patient's entire trajectory.
It is brilliant in its simplicity. But we also have to acknowledge the immense pressure this shifting landscape puts on those nurses and healthcare workers.
Because nurses are increasingly working autonomously in non-traditional, unpredictable settings.
Out there in the homeless shelters, in the county jails, or doing street-level outreach under a bridge.
Often without the immediate backup of an on-site physician or a hospital security team.
And working in the community requires a massive mental and emotional shift for healthcare workers.
How so?
Well, in a locked hospital unit, the traditional model of care is very paternalistic. The staff is caring for the client. They're keeping them completely safe, controlling their environment, managing every meal and every pill.
But when you move out into the community, you transition to a collaborative relationship. You are no longer caring for them. You are working with the client.
Exactly. And that means you have to accept that clients will sometimes make choices that you, as the trained professional, completely disagree with.
It has to be one of the hardest things for a compassionate, highly trained professional to do.
It is. You have to accept that the client is allowed to make mistakes, survive them, and learn from them. It is not the nurse's role to protect clients from the normal, messy experiences of human life.
That brings us to the end of our journey today. We have covered incredible ground, from the emptying of the great state asylums to the realization that a discharge plan and a safe zip code matter far more than a clinical diagnosis.
We've explored the empowering, autonomy-driven world of the clubhouse model, the 24/7 dedication of assertive community treatment.
And the tragic reality of those who fall through the cracks into homelessness and the criminal justice system.
We've seen how interdisciplinary teams, led by deeply adaptable psychiatric nurses and powered by innovative telehealth interventions, are fighting every day to weave that safety net back together.
So as we wrap up, I want to leave you with a final thought to mull over, building on that very last point about the shift in how we deliver care.
That's a tough one.
If true recovery requires empowering patients to make their own choices and direct their own lives, how do you, whether you are a future healthcare professional stepping onto the floor for the first time or just an empathetic member of society, balance your deep, ethical desire to keep someone perfectly safe with their fundamental human right to make their own mistakes?
It is a profound tension, and learning how to navigate it is the true art of mental health care.
Keep questioning, keep learning, and we will catch you next time on The Deep Dive.